You know, some of my cardiology friends think of themselves as an endocrinologist, and some endocrinologists think of themselves as a cardiologist. Not literally, but from the perspective of the patient, we have a lot of overlap, especially in the area of prevention. I think cardiologists attuned to this challenge of preventing cardiovascular disease and diabetes have been listening all along, waiting for that moment where we say, our job, the fact that we spend so much time on glycemic control, is paying off for your patients. The only time we can say that that's true is if we are starting very early with our patients with diabetes, that we're diagnosing it at the exact time it occurs, which is hard to do on a population level, and we treat right away, because there is long-term data showing that that will protect you from cardiovascular events in the future. So as far as how do I go between and think about all of it together, diabetologists are cardiac minded. We have to be. We're basically treating a cardiovascular disease. There's one thing that you have to understand is that the genetics of the two conditions don't always overlap, and it depends on the condition you're talking about. Diabetes is actually multiple subtypes, as you know, but we're talking mostly about type 2 diabetes when we're talking about the two conditions overlapping. Cardiac disease is just this huge spectrum too, right? So there are patients who have genetic predispositions to certain conditions, and also who might have been born with some cardiac defects that don't appear until later, or they have valvular disease that isn't detected until later. So there's a lot of spectrum there. But if we're talking about the what you might call essential coronary disease, the patient with metabolic syndrome who has the tendency for both diseases, the steps are similar. We know that exercise and diet can be effective in maintaining weight, and it does appear that maintaining a normal weight and avoiding obesity is preventative. We also know, especially in diabetes, that if you lose weight, you prevent diabetes. That's been shown really dramatically in the diabetes prevention program. The other preventive strategies can be started when you have diabetes. So now the national guidelines suggest starting a statin therapy, starting statin therapy, as long as you have diabetes and you're over 40 years old. That is, depending on who you talk to, it's either a primary prevention strategy or a secondary of early cardiac disease, meaning it's secondary because there may be some cardiac disease already, but it's as far as what we have documented in that patient, it's actually primary prevention. I always say diagnosing diabetes early can actually prevent heart disease. Not the other way around, potentially, right? But so they overlap. Eat well, sleep well, and exercise. Those are the big ones. Endocrinologists haven't felt very powerful in the area of preventing sudden cardiac death. I'll tell you that I think cardiologists feel probably similarly. We're both in the same boat. What we do know in diabetes from some of the large trials looking at glycemic control, tight glycemic control we call it, where the glucose level is near normal in one of the arms, that having severe low blood sugar events does predict sudden cardiac death, the scenario you just described. So we don't know if that is an intrinsic factor in the patient, where they're prone to hypoglycemia. That's why they have the hypoglycemia, and that's why they also have the same tendency to have sudden cardiac death. But I've seen in my office patients presenting with a low sugar and their blood pressure is elevated just in that setting. So we know that it causes sheer stress and neurohormonal changes. So I guess I would say that I do feel like I have that perspective, and if I can prevent severe hypoglycemia, I might be really impacting the potential immediacy of cardiac disease and death. As I said, diabetologists, that we are just a subgroup of endocrinologists, and I do feel strongly that I'm an endocrinologist, and I do practice general endocrinology to some extent, but I have a pretty strong kinship to cardiologists, cardiovascular surgeons, and preventive in folks that do prevention in primary care and cardiology. So what's the benefit? Well, you know, Boston's pretty cold too, first of all. And second of all, being invited, you know, is very symbolic of the fact that we do have this condition we have to manage together. I just gave an example to a cardiology friend of mine of a patient who was on a new medicine that might be protective in heart disease, this empagliflozin, but it was given to a patient with a heart defect that actually made it difficult for them to get around on this drug because it could decrease your cardiac output temporarily. If the person who prescribed it, which actually thankfully wasn't me, had just connected with the cardiologist, and it needs to go vice versa, both ways, the drug wouldn't have been used. That we can't just apply all of these medications across the board. We have to know who the study selected, what the cardiologists were thinking when they did look at some outcomes, and they avoided looking at others. And you know, we need to work together in order to understand how to use these drugs.